Good morning, good afternoon, good evening. Welcome everyone, ladies, gentlemen, and non-binary friends to UWIHARP's Sexual Health Dialogues. I'm Monique Springer, Project Officer with UWIHARP, and I'm joined with Ms. Kenya Anderson, our Project Assistant, and Samuel, a technician from UWI's Classroom Technology. They will be providing some administrative and technical support respectively for us today. A very special welcome to our students, staff members, off-campus partners, repeat visitors, and to our new guests. I want to extend compassion and commiserations to our local and regional families and colleagues during this difficult time with the last severe eruption in St. Vincent. UWIHARP is the HIV Sexual Health Unit at UWI, and we seek to positively influence the sexual and reproductive health and wellness of the university population and wider Caribbean society. Our primary focus is the development of sexual health literacy among the community through programs such as our digital dialogues. These are informal sexual health conversations and will be held during the semester. They include the S-Files discussion series on a wide range of topics and the Shock series, which will focus on sexual health issues among our vulnerable Caribbean populations during COVID-19. You can look out for the flyers on our social media platforms, which include Facebook, Instagram, the UWI App, and also through UWI emails. There are a few participation guidelines and notices. All mics are muted and videos are turned off. Q&A will take place after the presentation and the mics will be unmuted as needed. We ask you to post your questions or comments during the presentation in the Q&A chat pod located at the bottom of the screen. We aim to address as many as possible at the end of the presentation. For those questions you couldn't get to, please email them to uwiharp@cavehill.uwi.edu before the end of the day, and we will address them shortly afterwards. The session will be recorded, and the recordings will be posted afterwards on our social media platforms, including our YouTube channel, UWIHARP Cave Hill. These will be done without sensitive personal discussions to protect participants' confidentiality. Please note that we cannot guarantee confidentiality in this public forum among participants, so be cautious about what personal information you disclose about yourself and others. It's safer to talk in general terms. Also, please complete the evaluation form that will be sent to you after the session. You can also suggest topics that you're interested in for us to facilitate. There are a few rules for the digital dialogue, some of which were adapted from the HIV 2020 online. UWIHARP's digital dialogues provide a safe space to address a range of sexual health topics using a sex-positive approach. We encourage participants to share their knowledge, experiences, and opinions in a respectful manner. You may disagree with views highlighted today. However, please be respectful of other outlooks, regardless of your religious or moral beliefs. Let us be mindful in the way we discuss sensitive topics. UWIHARP operates on a zero-tolerance policy for any kind of abusive, discriminatory, belligerent, or disparaging comments or actions that may cause distress to presenters and or participants. Persons who engage in any undesirable behaviors will be immediately removed from the webinar unannounced. UWIHARP follows the first do no harm guiding principle. At today's topic, we will be focusing on Caribbean women's infertility, causes and consequences. And in this conversation, we will also be focusing on male infertility as well. And it will be delivered by Dr. Damian Bess. And I'll just read his bio. Dr. Bess is a consultant obstetrician and gynecologist and a lecturer in the Faculty of Medical Sciences at the Cave Hill campus of the University of the West Indies. Practices obstetrics and gynecology both privately and the Queen Elizabeth Hospital, and volunteers at the UWI Student Health Clinic for a once-monthly clinic. His subspecialty training is in fertility, and he has established and run the QEH's fertility clinic over the past 4 years. His training is certified by the UWI Cave Hill, the Royal College of Obstetricians and Gynecologists, UK, and the University of Aberdeen. His published research includes papers on the benefits of weight reduction for improving fertility. This is his 5th presentation for UWIHARP, whose efforts he continues to support in raising awareness of various obstetric and gynecological conditions. Dr. Best enjoys music and plays the piano. He's also a member of the UWI Taekwondo Club. So just to give a little bit of context and framing thoughts around today's discussion, and this is the second time we're actually doing this topic. We did it 2 years ago, 2019 in April. And we received quite a few requests to either repeat it or to host the session. So here we are today. And it's actually quite timely as it marks the National Infertility Awareness Week in the US, which is observed during the 18th to the 24th of April, 2021, which is next week. Infertility is one of the sexual health taboos that is loaded with cultural assumptions and misunderstandings. This influences the way we either think about fertility or don't think about fertility. The way we talk about fertility, including the way we ridicule those we suspect of being infertile, which can also lead to the way we maintain silences about infertility. And this keeps men and women from talking about their experiences and or seeking the medical and psychological help and support that they need. There are different lenses to explore infertility, such as psychological, social, environmental, and spiritual customs and factors. Today, we will focus on the clinical perspective, as well as the impact of lifestyle decisions and behaviors on fertility. Fertility also needs to be addressed as part of gender equality and social equality issues in education and healthcare, according to Nargan 2015. And today we will be focusing on cisgendered individuals, that is where your sexual anatomy is aligned with your gender identity. Example, where you are born with a female anatomy and you identify as a woman. We acknowledge that this is not universal. There are some individuals, such as the intersex, transgendered, and other non-binary individuals who do not conform into the male or female categories. We recognize and honor diverse sexual orientation and gender identities. And I'd like to now invite Dr. Best to talk to us about his work in infertility and to give us some information and some awareness of things that we can look at with infertility. Dr. Best?
Thank you so much for having me as usual, Monique and Kelia. And I'm just realizing that your poster has in a sperm and an egg here. That's quite clever. All right, so why don't we just dive into it? I hope everybody's energy is up despite all of the ash and the COVID. I'm going to try to gather mine just to try to make this talk a little interesting. So I recognize that we'd have a diverse sort of attendees, group of attendees, including persons with medical knowledge, as well as persons who don't have a lot of medical background. So I said I would make this as simple and digestible as I could. So a few learning objectives at the top. We want to be able to understand what a man and what a woman certainly needs, as the topic of this presentation was meant to be women, in order to become pregnant to begin with. This is going to include things like hormonal influences and anatomical considerations. And we're going to use that basic knowledge to understand how problems in these anatomical and hormonal areas can result in infertility. We also want to be able to define infertility, also known as subfertility, and be able to give the different types of infertility based on the causes of infertility and basically whether it's a first time or subsequent time that you're having difficulty achieving pregnancy. I also want to explain to you how we investigate couples who are having difficulty conceiving and basically explain to you a few of the assisted conception techniques, namely intrauterine insemination and IVF, which are commonly things that people like to know about and ask about. So we start with women, and I think people are familiar with what the female anatomy looks like. certainly from the outside, but here, if we have a look on the inside, we can see the seat of fertility here. So we all started out somewhere within our mom's womb. I do like to say that, you know, we all came from obstetrics and gynecology. That makes obstetrics and gynecology pretty important. So here's the uterus. We've got fallopian tubes and we've got ovaries. So your ladies, your eggs come from these ovaries. You have one on either side. And through a process known as ovulation, the egg would go enter the fallopian tube. Sperm coming the opposite direction from the vagina would enter the cervix and travel through the uterus to meet the egg here in the fallopian tube. And then the new individual or conceptus or fertilized egg should come and deposit here, usually, to implant and grow. So a closer look here at an ovary. For those who are biologically minded, this would be a microscopic view of your ovary. And those who know this textbook, like some of my doctors in the chat would know that down here would say somewhere this is the ovary of a dog, but much and such the same in the human. We've got follicles. So lots of these little tiny areas here in the ovary which contain your eggs, and you're born with all of the eggs you'll ever have. Several million, and by the time you reach adolescence, they've somewhat reduced to 1 million or less. And in your lifetime, you will tend to release 400 of them in a process called ovulation, and you will lose several others. So this here at the center, you see a large follicle. This is what we call a dominant or Graafian follicle. This is the one that would ovulate. And the others that you recruit or bring up every cycle would tend to regress, die, and eventually you will lose sufficient that you would enter menopause, where you can no longer reproduce because obviously you're out of eggs and out of the estrogen that the follicles also provide. So we do look at your follicles and your ovaries and your uterus and everything through transvaginal scan in the clinics. And yeah, we tend to see these large fluid-filled sacs, and we call them antral follicles when we can see them on the scan, and they tend to tell us about your ovarian reserve or supply of eggs that you have remaining in your lifetime. Now, some women will actually have in excess of antral follicles, or in excess of 12 antral follicles in either ovary, and may even have them oriented in a string of pearls like this. I understand they're going to talk about PCOS in more detail next week, but this is what a polycystic ovary looks like. And yes, this demonstrates for us very well how we can see those antral follicles on an ultrasound. Also important in achieving pregnancy in a woman, or certainly her reproductive cycle and her reproductive lifespan, is this axis, we call it. So at your brain, you have, at the base of your brain, you have the hypothalamus, you have a little gland called the pituitary, and hormones between them will signal your ovaries to go through that process, whereby eventually you will release an egg or ovulate. So we can see some of those hormones here: FSH, LH, estradiol or estrogen, and progesterone being influenced throughout the cycle. So key for persons who are tracking their own fertility to note would be things like this LH surge here. So LH usually starts off low and shoots up just before the egg is released. So it's this signal that causes the eggs to release. And if you're doing home ovulation predictor kits, the ones that you put some urine on and they show you some lines to show that you're probably going to be fertile over the next day or so, that's what this is testing. Also, key to note is that what causes that increase in LH to cause the ovulation is this rise in estrogen, which outwardly the woman might see as her mucus, cervical mucus changing. So you know that you're tending to become more fertile and closer to ovulation when your cervical mucus goes from this thick and not so stretchy mucus to this very stretchy, looks like egg white between your fingers type of mucus. Right. So following ovulation, we do have a rise in this hormone here called progesterone, which is the next major thing that women look out for when they look for that change in body temperature. So they're tracking their fertility. They're looking for maybe a 0.2 to 0.3 or so degree Celsius rise in their body temperature, suggesting that they have ovulated. So kind of a late sign. It means it's happened already, but that's another thing that women tend to track. So aside from having an intact hypothalamic pituitary hormone axis and an intact uterus and so on, we obviously need to have working and efficient fallopian tubes. So this shows ovulation, and we can see here the egg being released into the fallopian tube. These little finger-like projections are called fimbria, and they take the eggs up and allow the egg to be wafted in this direction, where hopefully some little spermies can meet up with them. Right, so usually you ovulate one egg. Obviously, if you ovulate two, that does risk twins, but usually ovulate one egg and you have several million sperms swimming. Of course, survival of the fittest, one sperm should reach the egg and perforate, penetrate what we call the cumulus, and then this corona radiata, and then this zona pellucida. There's some big terms for what basically is the outside of the egg. So the head of the sperm contains the genetic material to pass on to the offspring that is lost into the egg. You can see here the tail coming out, and that's what allows fertilization to take place. So then the fertilized egg, a new individual, should divide into multiple cells. So we get 2-cell, 4-cell stage, and eventually we'll have a blastocyst, which is ready to hatch and implant here into the endometrium, or the lining of the womb. So all of these areas need to be pretty functional. The fallopian tubes need to be able to waft the egg to transport it. The endometrium needs to be receptive, and it needs to be able to signal the fertilized egg in order for implantation to occur. So anything goes wrong in those processes could potentially be a reason for infertility, and we will go into those a bit later. Similarly, men do have a genital tract. I know we don't think about it that much, but we have testes, which similarly to the oocyte, or the ovaries, are where the sperm are produced, or the gametes, if you wish. And unlike women who are born with all their eggs, men can produce sperm pretty much throughout their lifespan, but there is some decline, certainly after the age of 45. And once those sperm are produced, they can make their way into the epididymis here and into what's called the vas, or the ductus deferens. You might hear of vas deferens. We're talking about vasectomy, which is obviously disrupting the vas, or cutting it to separate two ends so that the sperm can't get out. But nice working vas deferens should allow the sperm to be transported all the way bypass the prostate and out through a urethra, once the guy has had erection and ejaculation. So there are some nerves involved as well in that erection process and ejaculation process, and similarly, those need to be working well. Can be damaged by things like, diabetes, chronic nerve disease, accidents and injury to nerves, that kind of thing. And certainly the pipes, the tubes, can be damaged by genital tract infections, chlamydia, and so on. So this is just a closer look at what happens in the testis. So you do have, similar to the woman on the outside, the progenitors, or the stem cells, or the early cells, which would become eventually on the inside sperm, which would be ejaculated after a process of emission in the epididymis and into the vas and so on. So that's some basic biology, pretty boring stuff. You came to hear about infertility. So where do things go wrong, and how do we define infertility? So WHO did update their infertility definition in 2017 to encompass 12 months of unprotected intercourse between a man and a woman, so heterosexual intercourse, vaginal intercourse, and then after that point in time, they haven't conceived, we can now diagnose infertility using that definition. And interesting to note, they call it a disease, right? So that means certain things to us. That means that there is a right and certainly a privilege to have health care which addresses infertility, and it should be treated with as much seriousness as other quote unquote diseases. How common is infertility? Well, it's kind of difficult to pin down a incidence. It is estimated that 1 in 7 couples in developed countries, and probably a similar number in developing countries, slightly lower, will have infertility within their lifetime. Trying to get a Barbados statistic similarly difficult, because it would be difficult to sample the entire population, ask everybody, hey, did you have problems getting pregnant? So in order to try to capture a local statistic, I did do an audit in 2014 to see, how many people coming through the gynecology clinics at QEH suffer from a delay in pregnancy meeting the WHO definition. And it turned out that overall, it was the 5th most common cause of infertility in our clinic, which is pretty significant considering we have things like uterine fibroids is number 1, postmenopausal bleeding and heavy menstrual bleeding. So it's pretty prevalent, 5.4%, and 6.2% of those who are coming back for visits. We can diagnose infertility as either being primary, meaning that this is the first instance where they failed to conceive. So they've never had a pregnancy at all, regardless of the outcome. So they've never had even a miscarriage or anything like that. That's primary infertility. And obviously men can have primary, women can have primary, and couples can have primary. Or we can have a situation where maybe they've conceived, they've had a live birth or stillbirth or ectopic or miscarriage or something. But once they've conceived in the past, they're now secondary. So again, you can have secondary man, secondary male, secondary female, secondary couple infertility. And we found in that audit that 1/3 of people were primary and 2/3 were secondary infertility. So vast majority of the people that we see here in the QEH tend to have conceived in the past, but now having difficulty conceiving again. So we do usually wish to see the partners together, because we know you need those sperm, you need those eggs, they have to come together in order for you to get a pregnancy. So basically, both people should attend if there's a delay of that couple becoming pregnant. They're both affected by decisions. They both need to understand what we're investigating, and they both are potentially involved in treatment. And the evidence has shown that the women are more receptive and happier with their care when their partner's in attendance. So something to be encouraged, and something certainly do encourage. And we do try to provide them both with written information about the situation, about what we're doing, how we're working them up, as well as the verbal information which they would anticipate. Important that we address stress. Stress does raise hormones like prolactin and cortisol, which obviously make it a bit more difficult to get into mood to have the regular intercourse that's required for pregnancy. And sometimes, just the sadness and the frustration from trying to get pregnant can worsen and heighten stress. So therefore, it is something that you should offer the couple counseling if they are of desiring such. Simple advice, which can easily be provided by even general practitioners, is regular intercourse optimizes chance of fertility. And by regular, we mean every 2 to 3 days. You might be surprised to know how many persons would come and they say that, we've been, having unprotected intercourse for years, but they're not really having that frequent intercourse though. So simple things every 2 to 3 days basically optimizes the frequency of deposition of sperm in the genital tract. And we know that sperm can live up to 3, maybe as long as 5 days in the genital tract to fertilize the egg, looking for that egg, you know. And also, if we delay time between them, not only are we lessening the chance of fertilizing the egg when we don't expect ovulation, but we're getting older sperm if he hasn't ejaculated, which are inherently, you know, slower and probably more damaged sperm. So that every 2 to 3 days, and you know, it should allow them to basically enjoy themselves and not stress out about ovulation time as well, is what we usually recommend. Smoking and alcohol are things that we like to discourage. Obviously, alcohol, if the woman gets pregnant, can be detrimental to developing fetus. For the man, it can also, if he's in excess, if he's, you know, gets drunk and stuff, can damage his sperm quality. Smoking cessation, and this is all smoking. A lot of people I find in infertility clinic do smoke marijuana. Smoking does age your ovaries quickly. So remember those nice follicles we saw before. So you'll find that smokers would enter menopause quicker because their eggs are used up. So it's definitely something we discourage when you're trying to become pregnant. Also reduces sperm quality and makes the semen more viscous and thick for the sperm to swim in. Lifestyle advice, usually body mass index. There are pros and cons to body mass index. Obviously, if people have a lot of muscle, their body mass index, which is weight for height, can be pushed up. But generally speaking, many people with a high BMI tend to carry a lot of body fat, which disrupts hormones and so on, and can make it difficult to become pregnant, both in the man and the women. We saw our hypothalamic axis, extra estrogen coming from the fat can disrupt that. Also, it damages sperm and egg quality as well. And when obese women are more likely to unfortunately miscarry and to suffer some conditions in pregnancy like diabetes and hypertension in pregnancy. So there is a role for BMI reduction when you're trying to get pregnant, to assist with becoming pregnant and in order to keep pregnancy and to make pregnancy safe. So good thing to recommend. Folic acid is one of the essential vitamins for creating DNA and certainly important for developing fetuses, particularly the brain and the spinal cord. So to reduce the risk of neurotropic defects. If the lady already has a high BMI, she would need a bit more of the folic acid, 5 milligram. The 0.4 microgram, which most women need, is standard in most prenatal vitamins. But if she has epilepsy, diabetes, or high BMI, then she would need a higher dose of folic, 5 milligram. Right, so we did mention this 1 year of unprotected intercourse to diagnose infertility as a usual point in time that you would seek help. However, we do know that not all couples are the same. So if a woman is above 36 years or older, it does become a bit more urgent. 6 months is a reasonable time to seek help. Certainly if there's a known underlying factor. So if you know you have polycystic ovary syndrome, endometriosis, maybe you've had chlamydia in the past that can block your fallopian tubes, it's better to seek help even immediately if required. So why do we think so hard about women who are older? Is basically what we said earlier about the supply of eggs declining with age. And this is a graph which came along with the NICE guideline, which basically demonstrates that in your 20s, your fertility rate is pretty high per 100 women after a year. A little dip here at 30, but then a sharper decline here after age 36. And then after age of 40, unfortunately, it really becomes pretty difficult to become pregnant, and after age 45. Which brings us smartly on to how we will evaluate you if you and your partner have come trying to get pregnant and it hasn't happened. So we mentioned eggs and they're being released and ovulation. And this photograph does show ovulation test kits similar to what you'd find in the supermarket, Massey or Get Well Pharmacy. You know, shout out to them. Or iMart will have those. Those are these LH predictor kits, like what I was mentioning. But formally, we want to confirm ovulation, not predict it. in your workup, we would tend to check a blood test called progesterone, which we showed earlier, tends to climb and change your body temperature after ovulation. We do trying to check that in the middle of your second half of your cycle. And that particular level, if it is high and climbed and peaked, would confirm for us that you've ovulated. And if you haven't ovulated, we will look for underlying cause for that so that we can determine the best way to help you to ovulate and release your eggs. For the man, the standard test is going to be a semen analysis, which is a check of how the sperm are in terms of quantity, numbers, concentration is the number of sperm swimming in the fluid, but certainly as well how well they move, which is the motility, and how handsome they look, which is the morphology. And with those things being basic investigations that even GPs help us to do often, and before referring to fertility specialist care or gynecological care, the next step we would normally do, if those are absolutely fine, is to see if there's some sort of blockage in the pipes that we mentioned, the fallopian tubes. As obviously a blockage could inhibit the sperm from reaching the egg and the egg from coming back to implant. So here demonstrates a tubal check with a little balloon catheter in the uterus. This one particular with air and saline would be a ultrasound evaluation called a HICOSI or saline sonogram, where we inject some saline with bubbles, and that should show up nicely in an ultrasound. The X-ray equivalent would be what is called a HSG or hysterosalpingogram, pretty common. And here on the right side, we're showing the gold standard test. So if those other things haven't worked, or you have a doubt, or maybe you think the woman might have a risk factor like past chlamydia or something, or past abdominal or pelvic surgery, you might opt to do an operation where you put a camera through the navel and have a look while injecting some dye. So the dye will come through the cervix just like this, and you can see it's colored blue. So it doesn't match really with the pinks and yellows in the abdomen. So then we can see the fallopian tubes tinge blue, and then blue coming out would tell us that at least one fallopian tube is working. So yes, we check ovulation. And if you're not ovulating, we call that anovulation as a cause for infertility. Yes, we check for sperm parameters. And if your sperm parameters are out, we call that male factor infertility. And yes, we check fallopian tubes. And if your tubes are blocked, we call that tubal factor infertility. And then this diagram just shows us the distribution of those factors in the QH gynecology clinic as of 2014 and that audit. And far and away, the most common reason we had was failure to ovulate. And all of those were due to polycystic ovary syndrome, which affects 1 in 10 women. Pretty common. Male factor should normally represent about up to half of infertile couples, which is why we emphasize the importance of the men coming along. But it seems as though here look like one, which 1.6%. Combined factors, two of them 16.1%. And I would suspect that this was due to, prior to us instituting a fertility clinic, hardly any of the men used to show up. And hardly any of the men used to do the semen analysis. So it was very difficult to diagnose male factors. So I think that perhaps that distribution would be different if we were to repeat this audit today. Right, so diving a bit deeper into some of the causes of subfertility, we mentioned male factor as a cause, and we can see, I did mention that handsome sperm are more likely to have good DNA to fertilize eggs. And you can see here that some abnormal looking sperm probably don't have the best DNA, and as a result wouldn't fertilize eggs so well. And things like defects in the tails and the parts that contain energy for the sperm to swim can obviously cause problems with sperm motility, which means they don't swim as well to meet the egg, which can obviously be an issue. Semen analysis tests are available at QH, if we're seeing you there, at some private laboratories, even at my practice. And we tend to compare them to WHO values, and these are lower limits, which represent them having done an international sort of bit of research whereby the fifth centile, which is the lower 5% of men, below this would represent the fifth centile. So in essence, you have fewer than these, your chance of naturally becoming pregnant is much reduced. If you get one abnormal one abnormal semen analysis, meaning that you either have reduced concentration or reduced motility or reduced normal forms, basically you should repeat it just in case it was due to a temporary issue with the man's health, or maybe he's been smoking and he's given up smoking or something, and that might yield an improved semen analysis. The rule of thumb is we do it after 3 months, because we know new sperm are made after every 79 days. But if it's profoundly abnormal, like if he has no sperm, it's probably better to repeat it right away. But yes, I can't underscore enough how important it is for us to check both sides of the equation, including the semen analysis, when evaluating couples for fertility. So ovulation problems, we did mention. I don't need to go too much into PCOS because that is the topic of next week's talk. So put that in your calendars, guys, and we'll see you next week for PCOS. But just to show that the cardinal features would be, in addition to irregular periods, which are a sign of not ovulating, they might have things like a raised level of testosterone, which can cause them to have excessive hair, maybe on their face or their abdomen, their back, and so on. Might have obesity as a result of the hormone imbalance, which favors a lot of insulin in their body. And obviously, we do recommend that they reduce carbohydrate and high glycemic index foods in order to try to improve their hormone balance. Sometimes use a drug called metformin as well, or inositol, to help with that. And they very well might have what we call polycystic ovaries on the ultrasound, where we showed earlier lots and lots of those small antral follicles on either ovary. Important to underscore the fact that you don't need to have all three of those features: the testosterone, the irregular periods, and fail to ovulate, and the polycystic ovaries to have PCOS. You just need 2 out of the 3. So you don't even need to have an ultrasound to diagnose PCOS sometimes. Next big factor for the women, which could be common in persons who've had lots of unprotected sex with multiple partners and contracted things like chlamydia in the past, would be tubal factor. So chlamydia is the most common cause worldwide of tubal factor infertility, because it does cause some what we call adhesions, scarring, things to be stuck together, which can twist and distort and block the fallopian tubes. You can even have scarring inside the uterus as well. Maybe if you've had a bad infection, or maybe an infection after a miscarriage and had what we call a D&C, which is a kind of procedure to remove pieces of tissue that have left back in the uterus. You can have adhesions being formed in there. And the tubal factor, the blockage can occur anywhere in the fallopian tube, really. Other common cause might be previous surgery with scarring, things like myomectomies, which are removal of fibroids, appendix that rupture and stuff, can cause very bad adhesions, and things like endometriosis as well. So endometriosis, again, we talk a lot about this, and last month was Endometriosis Awareness Month, can cause infertility, even if it's just a little bit of spots like this. This is called probably mild endometriosis. Somehow it seems to make the environment for fertilization with the sperm and the eggs hostile by releasing inflammatory mediators. It just makes the environment kind of not conducive to fertilization. But the severe endometriosis, clearly, endometriosis basically is when you have bits of tissue similar to what comes out when you have your period within the abdomen, maybe outside the uterus here, and it bleeds just like when you're having a period, but it can't escape. So it stays in there and it causes all this scarring and adhesions, and this can destroy ovarian tissue and twist up the organs and twist the fallopian tubes and can cause blockages. So while mild endometriosis like this can cause infertility from inflammation, this severe, in addition to that, can also cause anatomical blockage. Um, Monique did mention that a lot of my research published is on obesity and fertility, and I did mention these things that yes, in women, obesity can mess with ovulation, particularly in PCOS. It can cause problems with the cells of the lining, the endometrium, can cause problems with egg development, poor embryos, and if you're treating them, obviously sometimes you need more medication to treat them. So always benefit to reducing um, body fat if you have an excess and you're trying to become pregnant. But similarly, men are not exempt in no way, form or fashion, because if you have a lot of abdominal fat, again, that produces estrogen. It can block your hormones, and fat can increase the testicular temperature if it hangs, and testes are hanging in sacs for a reason. They're meant to be cool to produce sperm. And it seems from observational research that when there's a male partner's obese, the pregnancy rates are also lower. It thought potentially could be due to problems with sperm DNA and so on. So always a role for reducing body fat in both partners. Last factor we want to talk about is that called unexplained infertility. So having checked for ovulation, and she is ovulating, having checked the sperm, and the sperm are great, having checked for blockages, and there are no blockages, what you've left with is unexplained infertility, which I suppose psychologically, it's kind of, for the couple, they want an explanation, and for you to say, oh, well, there's nothing that we can find, it kind of sometimes can throw them off. The prognosis tends to be pretty good up to 2 years. After 2 years, then basically the prognosis does seem to decline, and it's better to offer them IVF at that point. Although there might be some other options, but trust me, very often they would spontaneously conceive without even any intervention. If we do intervene, then often I might offer them in one of these assisted conception techniques. We are mentioning as one of our objectives, assisted conception techniques in the Caribbean. And this one is called intrauterine insemination. So it sounds like intrauterine, putting some semen into the uterus, but it's a bit more involved than that, because you can't just ejaculate into a uterus, because it's full of impurities and stuff that can cause scarring and stuff that will make the uterus contract, prostaglandins and that kind of thing. So it does need to be prepared by a specialist, andrologist or embryologist, who would wash the sperm, centrifuge, spin it, that kind of thing in the media, maybe make it swim up or get somehow improve the concentration and the movement, the motility. And that very much improved and washed and clean set of semen, which is drawn from the top, is drawn into a syringe. And a very fine catheter is placed in the uterus, and the prepared sperm is injected there, very close to the entrance of the fallopian tubes. So you can see that there could be some benefit to having a better quality concentrated and motile sperm sample very close to where they need to swim to, bypassing all the vagina and the cervix where there's the mucus to go through, and getting all the way up there. There might be, of course, some benefit to that, and that can be applied in unexplained infertility, mild endometriosis when there are no blockages, and sometimes in mild male factor, where these special preparation techniques can improve the sperm concentration and movement, right? Fairly simple technique, which doesn't need any anesthetic. We just need to make sure that the sample is delivered where it needs to get at a point in time where the woman is ovulating, or as very close to ovulation as possible. And that's where your ovulation predictor kits come in. Aside from that, there is in vitro fertilization, which is offered locally at the Barbados Fertility Center. And this IVF basically was designed for women who, in the initial phases, who had blockages in the fallopian tubes. So if you've got tubal blockage from whatever reason, past pelvic inflammatory disease from bad chlamydia, past surgical blockages or what have you, maybe you had your tubes tied or something, then IVF is right for you. Or if you've got severe endometriosis, or maybe you've gone through the gamut of ovulation problems, or maybe this severe male factor infertility, then IVF is the way to go. And IVF is offered locally at the Barbados Fertility Center. And it's a process whereby here we've got these antral follicles we showed before. We're basically going to be supersizing your follicles. So rather than producing one dominant follicle, we're producing loads and loads using FSH, the same what one your body makes, but in injection form, in order to get all these follicles while we're controlling your body and stopping you from ovulating all of these lovely follicles. So what this here is that's coming into this follicle on the ultrasound is what we use to collect the eggs. It's kind of a needle-like device. So you have a vaginal ultrasound here. You've got, we would have had some painkillers and some sedative, and the vaginal wall isn't that thick when the ovaries are big like this and very close. You can gently introduce the needle through there and draw the fluid from each follicle. The eggs should really be in there. That usually follows 36 hours after an artificial ovulation process, given a hormone called HCG to prepare the eggs for collection. So yeah, this is a summary here. So they consult and they have a reason for IVF. They do their blood work and the ultrasound. They get the stimulation. The needles will look like this. They look big like that. Okay, don't be afraid. Once that they've reached this stage of lots of yummy follicles, then they can get their trigger, ovulation trigger, and the eggs collected, which the lab would obviously handle and decide on IVF, which is the in vitro fertilization. In vitro literally means in dish. So they might have this in an incubator and incubate the sperm with the eggs. Or if there's very little sperm or very poor fertilization in the past, they might not just incubate the sperm and the eggs and do IVF. They might actually do what's called intracytoplasmic sperm injection, or ICSI, where they actually have the few handsome sperm they can find, inject them directly into the eggs to optimize fertilization. So fertilization should result, hopefully, in some embryos that survive to day 3, maybe day 5, where you can get blasts stage. And then this here represents stirrups. Basically, the lady comes in similar to the IUI that we saw before, and a little catheter with embryos is put in there, usually 1, maybe 2 embryos if the quality isn't as great as you would like, and the rest are frozen for future use. And once she's had an embryo transfer, she would generally getting some progesterone supplementation, maybe some vaginal inserts to help keep her uterus quiet and make her lining conducive to implantation. And 2 weeks later, she does a pregnancy test to see if it's worked. So we call this a cycle because, if she hasn't become pregnant, she can go back through. Obviously, if she has some frozen embryos, that can be useful as well, that she doesn't have to go through the stimulation process again. So that's basically what IVF is as an assisted conception technique. Very useful for tubal blockage, terrible endometriosis, or maybe if you've had very long unexplained infertility or gone through ovulation treatments and that hasn't worked out. So that's basically what I came to tell you today. So in summary, infertility, more common than you think, up to 1 in 6, 1 in 7 couples. And yes, it affects couples, not women, not men, couples. Thus, you should see both partners together, evaluate them, take their history, take the story down, do all the tests that are required to get to a diagnosis. You're asking, are there eggs? Are they sperm? Are they meeting in your evaluation? So we do check after a year, but it can be much earlier if you're older or if we suspect a reason for infertility. Definitely should be taking folic acid when you're trying to get pregnant, because that is the key time to reduce the risk of certain problems, neurotube defects, spina bifida, help brain development. You take that right up to 12 weeks of pregnancy. And my often used catchphrase at the end of consultation is sex every 2 to 3 days, and you might not even need us. Thank you very much for listening to me. At the request of Monique, I have left some contact details here, and the QR code does give you a contact card if you would scan it.
Thank you so much, Dr. Beth. As always, that was very, very engaging and informative. I see we have a couple of questions. I'll let Kelia field those questions, but I do have some myself. I think I'll just ask one or two questions if I can before we open the floor. Can you say what are some of the factors preventing women and couples from accessing, excuse me, clinical care for infertility here in Barbados? Maybe anecdotally, not necessarily from the research necessarily, but from your patients and what you've seen coming to see you mainly at the hospital.
Yeah. So certainly, I would say some of the major barriers are stigma. So it's kind of, you need to recognize this is a problem, and WHO even says it's a disease and there's help. So a lot of people in the Caribbean culture, I suppose, might be not less than willing to discuss problems getting pregnant, despite the fact that, you know, they're trying and not getting through. So that might be the problem coming forward. But once they do come forward, obviously we do have dedicating and willing services for them. You know, even if they go to a polyclinic or a general practitioner who can start the workup, they refer into any gynecologist or fertility clinic at the QH is established now, which accepts direct referrals. Even patients can self-refer. And certainly private practices are willing to accept patients. So there's lots of avenues to go through if they can overcome that barrier, that mental and psychological barrier of, you know, I don't need help. You know, it's going to happen. You know, this thing of, oh, relax, man, it's going to happen, man, you know.
Yeah. Great, yeah. Thank you for that. And then the other question I have, the fertility clinic then at the hospital, is that covered under the national health cost budget for the QEH, or patients have to pay for these services?
Right. So
some of the services.
Maybe I should probably let you know how the clinic started. So basically, you see, I did that audit. That was prior to me actually taking it upon myself to, you know, travel to overseas to get some additional training, because I wanted to see, you know, what was there a role, was there a benefit, was there a need, and I felt that there was. When I came back, I did basically, you know, I got permission to take those patients out of the gynae clinic, because obviously it is a couple's issue as opposed to a women's issue. So while gynae clinic is going on now, I do see those who had fertility referrals separately, so that we can see the couples together. And in times of COVID and ASH, online consultations also play a role here. So that basically, as an offshoot of the gynae clinic, meant that it's basically publicly funded and doesn't require any additional fees. So in terms of the evaluation, the workup, and treatments covered by the Barbados Drug Service, so that would include things like letrozole and clomiphene and so on, free at the point of care. If they need assisted conception techniques, IUI, I do that privately, but that's not available as yet at the hospital, and IVF is not available as yet at the hospital either. That's at the fertility center.
Great, thank you so much. So that clears up for me that the IVF is available with the fertility center with Dr. Skinner. Is that correct? Yeah. Only currently.
Yes.
Right. Okay. Great. Thank you so much for those responses. Kia, I'll let you field the questions to Dr. Best. Thanks.
Sorry about the cough. I don't have COVID. I think I said so already. We did the COVID talk. I cough a lot. I have reflux.
Presentation.
Thank you.
First question is here. Can prolonged use of OCP impact a woman's infertility? Is it advisable to stop using OCP after a certain period of time? And two, what is what current research is suggesting? What is the current research suggesting re COVID-19 is vaccines and any possible impact on fertility?
Thank you, Dr. Date. Those are some PhD level questions. Right. So prolonged OCP use is safe for well-selected women and is not thought to impact your long-term fertility. Of course, the main risk of long-term OCP use might be the risk of, deep vein thrombus and other things, clots being formed. That's why you don't use things like Diane 35 and so on long-term. Those are for hirsutism and stuff only. In some instances, while you're on the pill, that can cause suppression of your hormones, but generally speaking, on stopping them, you do have a rebound fertility, and even if you miss a day of pill in the wrong part of the pattern, you can get pregnant. So I wouldn't say that prolonged use impacts fertility as the final answer. Current research around COVID-19 vaccine and impact on fertility. So COVID-19 is not known to impact fertility, neither are any of the vaccines. So the main vaccines in use at present would be your Moderna and your Pfizer, which are your RNA vaccines, and you've got your Johnson and Johnson and your Oxford AstraZeneca vaccines, which are viral vector vaccines. They did not enroll pregnant women in those trials, but some of the women did become pregnant during trials, which suggests to me and suggests to the researchers that it does not impact fertility. And this is in the news often. People are suggesting, oh, you might get pregnant, but no, there's no evidence that it affects fertility. And certainly there hasn't seemed to be any evidence that, pregnant women suffer any adverse effects so far.
Thanks, Dr. Bess. A quick question before Keelia moves on. You probably said it and I missed it. Can you say what the OCP is, please?
OCP stands for oral contraceptive pill. Generally speaking, we would most often refer to the combined oral contraceptive pill, which contains estrogen and progesterone-like hormone, progestogen. And basically what those do are they stop your ovulation process temporarily while you're on them, while mimicking your natural hormone cycle. So you still see a period and stuff. And as a result of stopping you from releasing your eggs, they reduce chance of pregnancy. So quite commonly used in young women to regulate periods and prevent pregnancy.
Thank you so much. Keelia, you can continue with the question. Sure, thanks. Thanks for that explanation, Dr. Bess. As it relates to unexplained infertility, how common is it and how can we normalize infertility in the Caribbean? As most women tend to keep these kinds of medical issues to themselves, worsening stress and overall mental health.
Yeah. Thank you, Dr. Whitehead. Now, Dr. Whitehead's a genius, so that's why she asked me a genius level question, for which we kind of probably don't have answers. So in unexplained infertility, up to 25% or so, usually in most of your textbooks, would be unexplained. So if you're roughly saying a quarter ovulation, a quarter male factor, a quarter tubal factor, that other quarter would be unexplained, right? Again, difficult to quantify infertility statistics because you don't have population-based epidemiology. It's usually smaller samples. So these are rough estimates and you won't have any specific numbers to play with. But how can we normalize infertility in the Caribbean? I wish I knew. we can only continue to do the advocacy work that we are doing. So, talks like this one, where we air these grievances and these situations and issues. Um, Let people know that things are accessible. You know, doctors like yourself, Rebecca, talk to patients. Um, and yeah, with respect to the stress and mental health, again, offer them counseling if they require, and be supportive. It will take time and a lot of effort, but we can get there.
Thanks, Dr. Beth. I do agree with what you were saying in terms of normalizing these kinds of behaviors.
Uh, I'm losing Kilia just a little bit.
Can you hear me better now?
I heard the last bit, the better now. Um,
I was just agreeing with your point
all
made in
right,
terms of normalizing um, infertility among women and couples and encouraging them to seek the services as they are available to them, as well as not only infertility, but counseling, especially in these times. We have to see counseling as a positive and not as a negative.
absolutely.
The next question is saying, you mentioned chlamydia in your presentation. How does herpes, gonorrhea, and their impact on infertility?
Right. Thanks for that question. So chlamydia is often mentioned because it is the common one, and through its impact on the fallopian tubes and causing that inflammatory response through the infection, causes the tubes to be blocked and twisted and that kind of thing. So gonorrhea as another cause of pelvic inflammatory disease has a similar kind of pathway by which it can cause those issues, adhesions and tubal factor and problems within the uterus as well. Herpes really not so much as an infector of you know skin and nerves and stuff. I can suppose that if it is painful enough that it can decrease the frequency of intercourse, that can be an issue. But as long as you can continue to have intercourse, then potentially, herpes doesn't have such a big role to play on infertility. Um, so yeah, chlamydia and gonorrhea are the big ones with respect to tubal, but yes, any other, say, genital ulcer disease like syphilis and so on that can potentially cause pain and problems getting, you know, having sex or distorts the anatomy could potentially be um, causes of infertility, but because of problems having sex rather than causing blockages. I hope that answers the question.
I hope it does as well. If not, they can just Kia, you're muted. Sorry about that. I hope, as Dr. Best shared, that did answer your question. If not, you can just respond in the Q&A and we will try to respond as soon as best as possible. Dr. Date is giving you props on your presentation. She said it was fantastic. So cheers to you,
Oh,
Dr. Beth. The other question is, can we offer IUI, and I hope you can explain what that is, as an outpatient option?
yes, we can, and we do in certain private practices, such as mine, and the fertility center also does. So just to recap, intrauterine insemination, or IUI, is where we would prepare a sample of sperm to make it, you know, more motile and better concentrated and more pure, free of impurities, and put it close to um, the up in the uterus where it's closer to the interior of the fallopian tubes. And yes, we do offer that as an outpatient option in private facilities. It does require cooperation from both the man and the woman, in that obviously we need sperm. uh, Usually the guy would come in about 2.5 hours before the expected insemination and give his sample. That's taken by the andrologist or embryologist and prepared over the couple hours, and then we inseminate. So this is an ambulatory option. They come in and they leave the same day. They don't even have to stay for the 2 hours of preparation time. Another advantage of IUI is relatively much lower costs for selected patients than IVF. Everybody's muted.
Great. Thank you, Dr. Best. And our final question, I hope everyone can hear me at this point. I know you covered it a bit in your presentation, but someone is asking, is fertility a purely anatomical and bodily process, or is mindset or attitude involved?
That's a complex question. So we do evaluate from the standpoint of hormonal issues, ovulation issues, tubal blockages, semen analysis issues, and so on. So from the scientific or medical standpoint, that's where we're coming from, and that's what we're looking to treat. I can't say that anybody's going to willfully say I'm infertile or fertile to say it's a mindset or attitude issue. I would say that the things that we addressed about stress and so on can play a role, because that does alter the libido or appetite for sex and frequency of sex. It does alter your hormonal balance and can cause problems with ovulation and so on. But as I said earlier, it's no relax and it will happen sort of thing. If there's genuine concern that there's a delay in becoming pregnant, we would do full workup and offer advice and treatment, and to address the mindset and attitude bits, counseling as well. Again, I hope I've answered that okay.
Great, Dr. Best. I think that definitely counseling will assist in determining the factors that play a role in that determination. Okay, so we have about 4 more questions. Monique, you can let me know how they are for time.
Yeah, I should probably also
Yes.
say too that I do find that quite a few people coming with fertility issues are highly motivated people. If that has anything to do with the mindset, they really want it. And some of the people chart things, they write things down, they bring all their ovulation kits and stuff because they really want it to happen. So the desire is there, but sometimes, it's not happening, and that's because they need help with some of the underlying issues. So that might boil back down to the mindset question as well.
Thank you so much, Dr. Best, because we're at 12 past 2 now. And Keely said we have a few more questions. Do you have more time with us, or
I'm on vacation, remember?
No, that's not my question. My question is, do you have more time with us?
I do have more time with you.
Okay. Maybe we could then ask one more question, Kelia, and then for the others that we can get to, you can either email or contact Dr. Best. He has his contact info up on the screen directly, which will probably be the better route to go. So maybe we could take the last.
There are 2 questions.
Okay.
Really, the last one was just for Dr. Best to give the QVH email address.
Okay.
But the first question is, how often would you do the IUI before doing the IVF?
No statistical information on that. I would say anecdotally, it is an option for selected people. So if they've had unexplained infertility or maybe a mild male factor, maybe there's a mild motility issue and they cannot afford IVF, and or they cannot afford IVF, I should say. So if the problem is amenable to IUI, there isn't any tubal blockage, she's ovulating, you know, sperm quality can be improved or is adequate enough that IUI is feasible, then it is a good option for them to try. If she is older, if there is a tubal issue, or if you've gone through the full gamut of ovulation treatments and you've reached the end of the road and they can afford IVF, then IVF would be the way to go as opposed to going through IUI, right? So it's not necessarily a go through IUI to get to IVF, and not everybody will need IUI because ovulation treatments will work if there's an ovulation issue. But for selected people, they can be offered IUI, which can offer some benefit.
That's our final question is asking, are there any dietary changes that you can recommend for males and females attempting to conceive?
That's just an interesting question. So, right. So let me start with the men. All right. Several angles to tackle. Obviously, if they're obese, we did mention that obesity plays a role. So we would want them to adjust their diet in such a fashion as to reduce body fat, which means reducing a lot of the sweets, especially sweet beverages, which obviously can add up calories very quickly, and increase physical activity. People don't realize that pastas and breads and stuff can raise your sugar and your insulin very quickly as well. It should aim to reduce those and prefer browns to whites. And yeah, so that should be some dietary modification in order to reduce body fat and improve fertility through that angle. I would say that aside from that, it might be condition dependent. So again, PCOS might tackle the obesity angle and trying to reduce their insulin spikes from glycemic sugary things. Endometriosis might prefer a bit less inflammatory diet. I can't really get into that too much. I'm not a dietitian, but you know, I'm just talking about some Mediterranean diets and getting away from the red meats and stuff might be good for endometriosis. But aside from that, no particular dietary changes that are universal. They've been shown that antioxidants might improve live birth rate in men with male factor infertility. So that's things with high vitamin C and vitamin E, which you can get in supplements. Some other supplements like inositol might be good for as a dietary supplement for women with PCOS because it kind of mimics metformin in optimizing your insulin levels and helping to ovulate. Yeah, I've tapped out. So it depends on the specific man, woman, or couple.
Great, thank you so much. Sorry, Kelia.
So we're just going to thank Dr. Beth for sharing that information. Like creating any diet for any individual is going to be different. So this is something I guess individuals will have to discuss with their dietitian, their gynecologist, their GP. Monique, I'll hand that over to you as that was our last question.
Sorry, I just clicked the wrong button on Lori Christian's question, which I would say I was going to answer live. So I would just say that the QEH fertility clinic is qeh.fertility.clinic@gmail.com. qeh.fertility.clinic, quite easy to remember, @gmail.com. That's it.
Great. Thank you so much, Dr. Bass. And of course, I have about 15 questions. So it sounds to me like that will be an interview another time. So I want to thank you so much for sharing with us today and for informing us. From what I gather, most and all the participants that responded found it very valuable and engaging as well. And I want to thank them for joining us today, and also to remind them if they're interested in the PCOS talk next week. You can look out for the flyers that will be coming soon. I'd also like to thank Kelia and Sami for providing some tech support for us today, and to remind you to complete the evaluation form that Kelia will send out. I take it now that everyone has Dr. Best's contact information, because they had asked to leave up that slide. And I think that's it from me today. And as always, it's always been very exciting to hosting these discussions. If you have any suggestions for talks for us to host, you can put them in the evaluation form that will come out shortly. So once again, thanks everyone, and enjoy the rest of your ASHI day.
Thank you so much, Monique.
Take
and
care.
you enjoy your ASHI day as well.
Thank you. Okay.
Thanks for inviting me, guys. And thanks
Bye.
everyone for
Take
coming.
care. Take
Have a
care.
great day.